So it's great to be here. I have no financial disclosures, but I want to talk about converting an impossible situation into a possibility. And specifically, I'm going to be talking about depression, suicidal ideation, and a little bit about PTSD. I don't have a slick 3-point summary to give you. This is going to be a little more philosophical, but hopefully you'll get a whole lot out of this. First, I want to talk about the happiness hypothesis. So how have we treated depression up to now? For decades, we have used enhancing neurotransmitters, such as the reward neurotransmitter dopamine. Take some of this, please, and pass it around, if you would. A little dopamine for you. We've tried to enhance the effects of another neurotransmitter, norepinephrine, the I am empowered neurotransmitter, and even, here you go. Thank you very much. And then we've got another neurotransmitter, that serotonin. I am so happy after having had a full meal. I don't want to leave you out. Oh, and I don't want to leave. Oh, yeah. I'm not going to leave you out. Anyways, what these neurotransmitters do is they make you feel happy. Unfortunately, these are treated by medications that are targeted at the synaptic cleft. Unfortunately, we find that we have to treat the patient with depression on a daily basis, kind of like a Band-Aid. It's only a temporary fix. It isn't permanent. It's kind of like happiness. Happiness will release some of that reward center, but it depends on exogenous factors like, I got a great job. I got a great residency. I've got a great amount of money that I'm going to be making. I've got a great relationship. But when that love runs dry, when the money is gone, and when you're burnt out, what do? So we might need to, first of all, think and rethink about the mechanisms by which we treat depression. No longer utilizing the synapses, but maybe rearranging entire neural networks. And there's actually a medication that does that. And that might produce something akin to what we see in people who have resiliency. They don't get burnt out. And people who have this intrinsic sense of contentment despite external factors. This is what we call joy. So it's time to update things. Unfortunately, depression is going to affect all of us. Whether or not we ourselves have had depression, whether we've had a loved one or somebody we know close to us with depression, or we're the treating emergency physician with depression. Here's the deal, ladies and gentlemen, boys and girls. Depression rates and suicidal rates have gone up by 10% over the last decade, despite the plethora of medications and antidepressants that we have. What's going on? It's the 10th leading cause of death in the United States, and there is an increased suicide rate in the medical profession. Medicine is the #1 suicide profession. More than lawyers. That's crazy. And guess what? You've probably heard this. Emergency medicine has been affected by suicidal ideation and suicidality. And if you are the treating physician for one of these patients, with the closing of our psychiatric centers, especially if you work in a rural ED, how many of you work in more rural settings? It's really tough to take these patients and transfer them because nobody accepts them. So what do? You keep them. You border them for 24, 48 hours, and this is worsening our condition in the emergency department. So maybe it's time to rethink rewiring instead of treating those synapses. And the future may be right now. So can we send somebody with suicidal ideation home from the emergency department? Let's find out. First, it's important to understand the evolution of antidepressants. Prior to World War II, we had things like opium. We had things like amphetamines and tranquilizers. They didn't do a very good job because they led to dependence, they led to addiction, and they led to inability to really go to work, right? Just like blah, 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 like that. So what was really amazing is that a new drug used to treat tuberculosis had an interesting side effect of mania, hypomania rather. And the discovery of this side effect property led to the evolution of these old MAO inhibitors, which decreases the degradation of some of these neurotransmitters, or cyclic antidepressants. And if any of you have been around for a while, when I was a resident, overdoses with these cyclic antidepressants were horrific, but they actually did induce a state of hypomania, but they would have some undesirable side effects. It would take several weeks for these to work, and they were therefore not a panacea to send a suicidal patient home. In fact, it was found that people would take these drugs as overdoses and kill themselves in a terrible way. Then in the late 80s, selective serotonin reuptake inhibitors and some of these similar medications came about, hopefully to target serotonin, that, I feel so satisfied about life neurotransmitter. Guess what, ladies and gentlemen? They don't work on every patient. You might have to take a cocktail of these to make things happen. And there's undesirable side effects like weight gain. But here's the big problem. They actually increase suicidal rates. Not too good. It's what I call in New Mexico, hypo bueno. There's lithium. Lithium can work, but it's an old drug, it's toxic, and it doesn't work quickly enough for suicidal ideation. But it is that one drug that actually does decrease suicidal ideation. Electroconvulsive therapy has been around since 1542, but it's not practical in our emergency department. It doesn't always work, and antipsychotics do not treat acute suicidal ideation either. So maybe it's time to reconsider a new mechanism, a new way to treat depression. And an interesting side effect of one particular drug got a researcher in New York named Brackman very interested in the hypothesis. And what happened is she took a bunch of mice and she put them in a box where there was some curio to enhance their curiosity, and the mice ran around and checked things out as a control. But then when stress was induced, guess what happened? They naturally hid behind that pillar of safety. They were stressed. This was the model for PTSD. But guess what? When these mice were, quote-unquote, immunized or vaccinated beforehand with this medication, guess what happened? Stress was induced, and they still went to that pillar. They were curious. This was like a vaccine for PTSD. This has only come out in the last year. We haven't tried it on humans, but there may be hope for those of us that do rescue work, healthcare work, or operational medicine, or those of us that are exposed to trauma. And it may help our patients with PTSD, but there's a big problem with this medication. And you know it well. It induces dysphoria, psychosis, but you've used it for RSI. You've used it to treat pain, acute pain, reduction of fractures. Yeah? Ketamine, exactly. Maybe some of you have used it for depression or chronic pain. Well, guess what? This medication works by rearranging neural networks. This is exciting, and that was the drug that Brackman and Associates used. What has it done in the emergency department? There's two studies, not very big, but one study from Yale had 14 people that had valid suicidal ideation according to a well-respected scoring system. After 4 hours of having received this medication, none of those 14 patients exhibited signs of suicidal ideation, and this effect continued for 10 days. Another study a little later demonstrated that of 49 patients, 44 had no suicidal ideation after 10 days. This is exciting. The remainder had a little bit, but what does this suggest to us? Well, there are some problems with these studies methodologically. Obviously, you couldn't blind the ketamine, right? You knew who was getting ketamine, and the doses were low, and I'm not sure why. But the good news is that ketamine can rewire entire neural networks. Can we send the acutely suicidal patient home from the emergency department? It may. If we can convert our happiness into joy and stop treating depression and SI and reconsider things like ketamine, we might be on to the road to the future. Thank you very much.